Yes, so my name is Dr. Jeremy Stone. I'm a consultant anaesthetist at Northampton General Hospital. I've worked there for 14 years now. For about 10 of those years, I've been the clinical lead for equipment in our department. I've also held the role of the clinical lead for obstetric anaesthesia. I recently relinquished that role to take up a slightly higher role in terms of rota management for the whole department. So really, I've worked across a range of different places. Most notably in theatres, I tend to work within those theatres where we do colonic resections for colorectal surgery. We've acquired robots now to underdo robotic colorectal surgery as well. So a lot of my work involves things like pre-assessment of these patients, particularly high-risk patients, including cardiopulmonary exercise testing, providing anaesthesia for patients having major colonic resections, and I also still cover labour ward 1 day a week where we undertake maybe approximately 4,000 deliveries a year. Patients undergoing a caesarean section are at quite a vulnerable point in their life, I think. They're often very anxious. So as an anaesthetist, we've got to try to manage and meet that anxiety. Most patients having a caesarean section have an expectation of being awake. So the majority of the time, we'll do an anaesthetic called a spinal anaesthetic, which allows them to be comfortable, pain-free, and awake for the delivery of their baby. Undergoing a spinal anaesthetic brings with it certain physiological challenges, combined with some of the challenges that surgery poses on the patient as well. So most women will end up coming into theatre, having a spinal anaesthetic, being nice and comfortable, and have the baby being born as well, so that everyone can be involved in the whole process. Well, I think some of the main problems that we face are the fact that we have a person who's pregnant. So one of the problems that you have when you're having a caesarean section, if someone's lying flat on a bed, then they've obviously got a very large bump that you can see. We can see this on the outside, and this large bump, this baby, the enlarged uterus, also extends inside the abdomen. The main consequence of that is it can cause aortocaval compression, which can reduce the venous return to the right-hand side of the heart and diminish blood flow within the aorta as well. These can both manifest themselves as hypotension. If you have any pregnant person lying flat on the back, they're quite at risk of aortocaval compression. During the caesarean section, particularly if we do a spinal anaesthetic, the spinal anaesthetic itself, it will block quite a large number of the sympathetic nerves within the body. The role of these sympathetic nerves is to provide tone to the vascular system. So the process of abolishing this will cause often quite profound hypotension. The body will try and compensate for this with a tachycardia or raising the heart rate. But particularly if there is an element of aortocaval compression, the body may be limited in its ability to compensate for this problem. Additionally, during a caesarean section, what we may wish to try to do is to use a drug called phenylephrine. The purpose of this drug is to cause widespread vasoconstriction to try to compensate and prevent hypotension, which can be quite detrimental to mother and potentially baby as well. The useful things for us to measure in a patient having a caesarean section, I guess the main difference for these patients is that they're awake as opposed to our colorectal patients who are asleep. So commonly, we're often alerted to the fact that something isn't quite right if a patient tells us they don't feel terribly well. The things we may see initially might be a tachycardia, but this can be a later than expected sign. Intraoperatively, hypotension is a common occurrence. However, if we're relying upon the fact that there's a non-invasive blood pressure cuff on the upper arm, this can take a bit of time to manifest itself. So really looking out for hypotension can be a slightly later than expected sign. Earlier things we may see might be, as I say, a patient saying they don't feel terribly well, but anticipating, preventing, and then treating hypotension is the one thing that can really make a big difference to how women feel, because it can really cause quite a significant amount of nausea and vomiting at a particularly vulnerable and important time in their lives. Intraoperative hypotension, particularly during a caesarean section, is when someone's blood pressure dips below the level at which normal homeostasis is maintained within the body. This may manifest itself as someone simply looking at a monitor and seeing a low blood pressure. So a blood pressure we may see could be 75/35. The consequence of this for the mother during a caesarean section might be nausea and vomiting, and that's one of the mainstays why we use a phenylephrine infusion to try to prevent this. This is clearly a very distressing thing for someone to experience during awake surgery, the sensation of nausea, the process of vomiting, particularly whilst they're trying to maybe bond with a neonate. But beyond that, there are wider concerning bits of physiology that could develop. So if we have elements where there's hypotension, which is prolonged, more severe, we start worrying about whether or not perfusion to other vital organs might begin to compromise their function, such as the kidneys perhaps. Most of our patients are young, fit and healthy, and in the main can recover. But I think it's certainly something worth thinking about, and if it's possible to prevent it, we should. I think the consequences for intraoperative hypotension during a caesarean section can be broken down into maybe early events and later events. Early on, the main manifestation of hypotension tends to be in the presence of nausea and vomiting, which can be distressing to the mum, awkward for the surgeon, and problematic when it comes to perhaps bonding with a new baby. Later on, the problems of ongoing hypotension, it may reveal the fact that there's perhaps something more significant happening. So it may alert us to the fact there's a problem. Initially, it's because of the chemical sympathectomy, because of the spinal anaesthetic, most commonly. But later on, if hypotension persists, it may make us think that there's a cause, perhaps ongoing bleeding. And then the consequences for the mother in these circumstances are that we have persistent reduction in oxygen delivery to the vital organs. If someone's hypoxic, you can often see an awake patient becomes agitated. If someone's hypotensive, then you may see that they perhaps also can become agitated under those circumstances as well. And if someone has ongoing hypotension because of bleeding and hypovolemia, it's not uncommon for us to need to give a general anaesthetic because of the fact that they may become agitated under those circumstances. More prolonged problems, very rarely we may see significant ongoing organ dysfunction such as in the kidneys. It tends not to be such a common occurrence on labour ward because our patients are young, fit, healthy and can compensate very well. So usually that's not a major problem. The most important thing to begin with really is to recognise it's likely to be a problem and to institute some preventative strategies. So the first thing that we should be doing is co-loading intravenous crystalloid fluid. So not preloading but co-loading. So instead of having a running drip at the beginning of performing the spinal, what we should be doing is at the moment of performing the spinal, when the local anaesthetic enters the CSF, at that moment we wish to open up the drip fully under pressure so we can institute a bolus of IV fluid at that moment in time. We know that's associated with a better cardiovascular stability. The other thing we do at that moment is to start the phenylephrine infusion, again to prevent hypotension. And finally, when mum's finished with the spinal anaesthetic and is lying flat, we institute some tilt of the bed to about 15 degrees. We use 15 degrees because it's a bit of a balance between obtaining enough tilt to prevent aortocaval compression and yet not having so much tilt that actually performing the surgery is difficult. In reality, what we end up doing is having something between 5 and 10 degrees so the surgeon can still operate comfortably and it reduces enough aortocaval compression to help ensure cardiovascular stability. So those are the three main things we do. And then secondly along, we want to monitor blood pressure as frequently as we can. So we have mum who's awake who can let us know that something doesn't feel right. But in addition to that, if we've got other monitoring techniques to measure blood pressure regularly, frequently, this will alert us to any potential problems. We heard about the Acumen Cuff a couple of years ago. We had been using the EV1000 platform, and then we heard from Edwards that actually there's a new piece of technology, non-invasive, that allowed us to monitor blood pressure on a regular, reliable, frequent basis. I think we started using it maybe about 2021, although COVID kind of interferes with people's memories a little bit. But it's been a few years now. It's been established in our hospital. We use it on labour ward. We have a machine which is available. So people are aware of it, people use it, and people make good use of it using the Acumen Cuff during caesarean sections. During a caesarean section, we apply the Acumen Cuff early on at the beginning. So when we're instituting the anaesthetic, we do the WHO chair, can place an IV cannula, and at that stage we place the Acumen Cuff. The reason for doing it like that is you have mum sitting down on the bed, awaiting to have the spinal anaesthetic, and it allows us to take some baseline readings of blood pressure and other wider cardiovascular parameters. So we can understand what the current situation is, what the normal situation is before other physiological derangements may kick in because of anaesthetics, because of surgery, and whilst mum is sitting, before she lies down, before any aortocaval compression kicks in. So it allows us to work out what the situation's like before we start, and therefore maybe what we should be aiming for intraoperatively. We have found the Acumen Cuff to be very helpful during caesarean sections. An example of this really could be that having a non-invasive blood pressure cuff on an arm, if we use it for monitoring blood pressure during a caesarean section, we tend to set it to a 1 minute cycle, so a near continuous measurement. However, in reality, you end up with discrete numbers during the caesarean section. You don't really know what the blood pressure is whilst it's measuring, and commonly I've had caesarean sections where the blood pressure cuff has failed to give us a result, a number, a measurement. The reason for this might have been movement artifact or sometimes a reason we don't always know, but you certainly have had moments where we've had prolonged periods of time, 7 or 8 minutes, without the blood pressure cuff delivering any numbers, any results, or anything meaningful information. And at the same time, we've had a lady with the Acumen Cuff on, and whilst that blood pressure cuff was cycling and not giving us any useful information, the Acumen Cuff continued to give us beat-to-beat blood pressure measurements, so we knew continuously all the time what the blood pressure was. So that gave us an element of significant reassurance and accurate information, knowing what the situation was throughout that period of time. Using the Acumen Cuff pre-procedure, it allowed you to fit it appropriately, make sure it's comfortable, and the patient says they're happy with the situation. It then allows us to obtain baseline readings so we know exactly what the situation is at the moment, and maybe it allows us to detect whether there is any current underlying cardiovascular instability prior to commencing anaesthesia and surgery. We often think that maybe patients presenting for surgery come in the most optimised situation, and that may be the case. It doesn't mean, however, that there aren't elements of susceptibility or cardiovascular instability. They arrive starved, so they could be dehydrated. So beginning this process of monitoring at the beginning allows us to see where we're at the minute, what the current baseline is, and what element of instability there already exists. During the procedure, I have seen the main benefits tend to be reliable, continuous blood pressure results from the Acumen Cuff, which isn't always obtainable from a standard non-invasive blood pressure cuff. It tends to be comfortable for patients. They consider it to be really less troublesome than the upper arm blood pressure cuff traditionally used, which is often the source of some complaints and problems and irritations during a caesarean section. And whilst there's an element of slight bulkiness, it's not a problem when it comes to the real life situation, and we can adapt if a mother wants to do skin to skin with a baby post delivery. That's something which easily we can work around. Post surgery, what you have is the patient hasn't had a period of time where their blood pressure has been going up and down on the cuff on their arm. They haven't got a bit of a bruise or a problem or a soreness, so that element doesn't exist. We don't use it post-operatively for monitoring. However, what I would say is if you manage to get things right intraoperatively, it's likely to reduce any post-operative problems maybe related to hypotension. Using the Acumen Cuff during a caesarean section will often give us earlier warning that hypotension is impending. The circumstances behind this might be early on when the spinal anaesthetic is developing. Usually we have a fairly good idea that we need to be looking out for this, and we do so. But the Acumen Cuff, combined with the lady herself telling us that she might not feel terribly well, will give us really good notice and prior warning that hypotension could be developing. When it does develop, we're then in a better position and better equipped to deal with it, to treat it and to remove it as a problem. Later on during a caesarean section, we often administer certain quite potent cardiovascular altering drugs. Commonly used are things like syntocinon or carbetocin. The effect of these drugs tends to be quite a profound vasodilatation on the cardiovascular system, often fairly short-lived, but certainly quite profound, and patients commonly will produce a quite significant tachycardia in compensation to try to maintain the cardiac output. There have been some reports in the literature of patients receiving a dose of syntocinon, a high-ish dose maybe, often at speed, which can contribute to significant cardiovascular collapse. So we've found that using the Acumen Cuff, we can see that hypotension is developing, know that it's going to happen, and combined with the knowledge of the fact that it's likely to happen, with better forewarning, allows us to be in a better position to treat this, or really to prevent it, through the use of intravenous fluids, or maybe a higher dose or a small bolus of phenylephrine as required. The additional thing I think we need to do, and that allows us to do this with the Acumen Cuff, is to tell the lady that she's having a medicine which might make her feel unwell, and if she does so, she can let us know. Non-invasive monitoring has made one main difference to my practice. It's kind of opened my eyes really to the fact that hypotension, whilst it does occur, I think that seeing hypotension, if it's measured with a non-invasive cuff, is a later sign of hypotension, and using the Acumen Cuff really lets us see that the hypotension is developing, it's coming. So a bit like when we're doing a spinal anaesthetic for a caesarean section, we know hypotension is coming, so we can take steps to prevent it. If the Acumen Cuff can look at the situation and tell us, similarly, hypotension is coming, we can take steps to prevent it. And additionally, what we might be able to do is to look for the specific reasons why hypotension is developing, rather than having a single blanket way of treating it simply with vasoconstrictors, which may be correct, it may be the wrong thing. The Acumen Cuff can let us target more specifically the specific reason why hypotension is developing, allowing us to treat the correct cause. On the hemisphere, my eye is initially drawn to the HPI number and usually the trend for this. So that allows us to see how things have been developing in the past bit of time, a couple of minutes, a bit longer perhaps, and then allows us to see what that trend is. So if HPI is rising, we might want to start thinking about why that's the case, checking with the surgeon maybe, seeing if the lady's okay. If that alerts us to the fact there's trouble, the secondary information allows us then to sort of look behind the covers almost to say, well, what's the cause of HPI going up? What's the reason behind potentially impending hypotension? And then what we want to look at is maybe looking at stroke volume variation, SVV, to say, well, is there evidence here to suggest that we have ongoing fluid depletion? Patients come to theatre starved, so it's not an uncommon problem. And that might be a thing that we can target with fluids to try to treat impending hypotension, or really to prevent it. The other thing we often look at is the contractility, the DPDT parameter. And that lets us see what changes there have been in that parameter over time, whether any of our drugs have caused any problems of myocardial depression. It might be a little bit more difficult to treat, but I think the first step is to understand what the underlying cause of a hypotension is, and therefore allow us to, if we can't necessarily treat it fully as we'd like, we can at least avoid the drugs which are incorrect. And the other thing we can look at is EA-dyne, which might give us an idea of how likely a patient will be fluid responsive in the event that fluid is the correct treatment for them. I find predictive technology really helpful during a range of procedures. Thinking about caesarean sections to begin with, I find predictive technology allows us a glimpse, a little peek, sort of around the corner into the future, to say, whilst we think things are okay at the moment, if predictive technology can look at a situation and say, well, there's a high chance, a high probability that instability, uncertainty, hypotension is likely to be developing, it allows me to recognise this and put in corrective measures early so we can prevent it. It's a little bit like this sort of technology is in all aspects of life. Our cars have it now. We have collision warnings, all sorts of things. So it's not a new concept for us to understand, but it's something that's maybe challenging for some anaesthetists to realise, that say, well, how can this help me? Can I trust this? I think the answer is yes. The key benefits for using the Acumen Cuff I find during caesarean sections tends to be early warning of the onset of potential hypotension before the surgeon tells you that maybe there's bleeding they haven't communicated to you about. It's not uncommon for there to be a situation where a more junior obstetrician is working hard, very focused, a bit task focused perhaps, during the caesarean section, during delivery. There's been difficult to control bleeding. We are unaware of it as the anaesthetic team at the top end. And we have this situation where the woman might be compensating very nicely, so you can have a non-invasive blood pressure cuff showing a completely normal blood pressure. And yet, if there has been blood loss of 6, 7, 800 mils, whilst the blood pressure and heart rate will be entirely within normal parameters, It's certainly true that the physiology is adapting and there will be impending hypotension. So the predictive technology of Acumen allows us to recognise this situation so that even before anyone in the theatre has verbalised there is a problem or even an impending potential problem, we can recognise it and begin to do things like cross-matching blood, giving fluids and addressing the problem and preventing a hypotension occurring. I've talked to patients having the Acumen Cuff a number of times. There are two main things that strike me. The first is they feel almost empowered to be wearing a piece of technology on their arm. It's quite a common occurrence for people to wear smart watches, smart rings even. So for a patient to be wearing something, you tell them, look, this is going to be helpful for you, this is reassuringly expensive. They feel involved with their healthcare. They quite like it a little bit. And what I've also noticed when you talk to them about it, you say, well, how does it feel? Is it too heavy? Is it too uncomfortable? Is it too tight? Almost invariably, they will say, well, no, not really. A good question to ask them is, does it bother you? And the answer always tends to be, no, it doesn't bother me. The opposite, however, when talking about a non-invasive blood pressure cuff is, it often does bother them. Not always, but certainly much more commonly. I think individuals and departments often find it difficult to adopt and institute new technology, particularly challenging when you've got a nice, comfortable way of doing things, you've got monitoring with which you're familiar, and you perhaps don't see a need for change. So those obstacles come really in the form of people being uncertain about new technology, uncertain of how to use it, uncertain of what it means, uncertain of what they should do. So the things we have done to try to overcome those sorts of barriers included training for people. So having a group of super users of this type of technology, people who had some training with the Acumen Cuff, knowing how to put it on, how to plumb it together, how to fit all the machinery together. It's not complicated, but when you're faced with something for the first time, if you haven't done it before, it can be quite difficult. The other thing we found that's been very helpful is to have clinical specialists on the shop floor coming into our hospital quite frequently really to help with people setting up this technology so that in the event an anaesthetist is using their brain to say, well, I'm going to try to figure out how to put this all together, which finger do I put the Acumen Cuff on, does it matter, I'm not sure. Having a clinical specialist to help us put that all together, that individual anaesthetist can then say, oh, right, that's lovely, I can just use my brain now to looking at the information, interpreting it and using it appropriately. Here at Northampton Hospital, we've often been quite early adopters of new technology. This has been manifest in things like monitoring of vapour and things like isoflurane in the anaesthetic room. We did that 15, 20 years ago before other hospitals did. So we have had a tradition of being early adopters of technology, which is quite helpful when it comes to my wider colleagues using a new piece of technology like the Acumen Cuff. So having people be interested is quite the first step. I think having people understand the potential benefits as well. So it can be felt as quite a criticism if someone hears their anaesthetic they're giving perhaps isn't the best. They may get defensive. So having an explanation as to what can be done to make it from being really good to being even better is an easier way to understand the situation to implement new technology for patients' benefit. I think we can look at that as an individual, myself, or the whole department. What we've been able to gain access to is the ability to apply Acumen technology to a range of patients in labour ward and wider afield as well. And what it's done is open many people's eyes to the fact that this technology is available to allow us to then see if hypotension is going to develop. And more people are saying, today I've got a case where such and such are the circumstances, and this is going to be more ideal for me to be using this type of technology. That's the sort of thought process which is more common now these days, where someone says, this is a challenging situation, I require some more advanced monitoring to help me to manage it more appropriately. We implemented teaching with the help of Edwards and some clinical specialists to develop a small group of people with a deeper initial understanding of how the Acumen Cuff works, what the information means and what we should do with it. And then what we decided to do was to have a small group of these people who are familiar with the process and the technology, and then to have them really be available within the department as sort of expert super users, so that in the event that a colleague in the theatre next door wishes to use it, it's relatively easy just to say, well, I'll pop in next door, I can help you with fitting this, I can help you to decide what to do with information, and we can work on it together, and then word slowly spreads over time to allow wider understanding in the department to spread out. Generally the feedback is very positive. I think it partly depends on personality, because you have some people who are really keen early adopters of technology. You kind of tend to know the people who say, well, for my anaesthetic, I'm going to have all the specialised bits of equipment for every single step. And they tend to be people who will be readily to adopt this type of technology. And in doing so, their feedback is very positive. They find the Acumen Cuff easy to use, they find the information easy to understand, and a protocol easy to implement. There are always some people who are a bit mistrustful. There's very little we can do about them in the long term. We do use a protocol in obstetrics for our non-invasive monitoring. It's attached to the machine, so it's not easy for us to lose it, so it's always readily available for people to see. It's laminated, attached, clear and easy to follow, and it gives you access to the type of information that's displayed on the monitor with easy to follow instructions, so that in the end you can follow the correct path, whatever the situation is, to implement the correct decision. The different outcomes I've seen are partly amongst my colleagues who talk about it, are keen to use it and keen to implement it. We haven't yet really done any measurements specifically for looking at different things like length of stay or maternal satisfaction. However, what I have noticed anecdotally seems to be a greater degree of overall cardiovascular stability within theatres. Certainly in the times I've been in theatre, when people have been using it, it allows people to just to tune in to what's happening, to prevent problems and to allow for greater stability. I think the future for non-invasive monitoring in our department in labour ward for undergoing caesarean sections is likely to be an increased use in the frequency of this type of monitoring. I wonder maybe if the monitoring becomes slightly easier to use, a bit simpler over time. The same is true of many other technologies we see in healthcare and wider afield, so that with user feedback you're able to have a situation where it's even easier, even more easy to apply, to use, and more frequently able to be used by the clinicians to get the outcomes they need.